Obstructive Preventive Cardiology, and good friend, past president of the American Society of Preventive Cardiology. Great work in preventive cardiology. Steve and I were recently in Egypt at the Preventive Society meeting, and everybody loved Steve over there. He gave a great talks, and even dived in the big sea and did some scuba diving while we were there. So, Steve, nice having you back.
Great. Thank you, Mahfouz. It is wonderful to be here in Sarasota. I live and work delightfully every day in Rochester, Minnesota at Mayo Clinic. When I woke up 2 days ago next to my beautiful wife of 33 years, it was 32 degrees below zero without wind chill. I wanted to open the sliding glass door and put some water out in the bird bath, and it was frozen shut. I couldn't get out. Today I woke up and it's 68 degrees above zero. That's a 100-degree change. With wind chill, it's about 150-degree change. So, Mahfouz, I am so happy to be here. Thank you. Thank you for inviting me. What we'll talk about, for the next few moments will be familial hypercholesterolemia. And you have to recognize it before you treat it. Do any of you in the audience know anyone that has familial hypercholesterolemia? Do you treat anyone that has familial hypercholesterolemia? Here are my disclosures that have nothing to do with what we'll talk about today. But the goals are to learn the causes of FH, or familial hypercholesterolemia, be able to know when to suspect it, because it's right under your eyes, and recognize the physical exam and the history, family history, that's consistent with familial hypercholesterolemia. So here's JB. It's a young man I saw a few years ago, age 13 and a half. At age 6, he was found to have homozygous, and we'll talk about what that means, but it means you get a gene from each parent, familial hypercholesterolemia. At age 7, he had a coronary angiogram that showed he had a 60% left main stenosis and an 80% right coronary artery stenosis. So here is a young man who hasn't even reached his teenage years and is already facing a life of coronary disease and bypass. And very interestingly, here is his cholesterol values. And what you can see is this is the number, maybe you can't read in the back, but this number is 1,000. And this line here is his total cholesterol, and the next line next to it is his LDL, or bad cholesterol. You can see that he got on some drugs, some statins. It came down, his LDL down to 400. Then when the PCSK9 inhibitors that you'll hear talk about later, these new injectable drugs came out, it went down a little lower. But he has a lifetime ahead of him of troubles, obviously. So what is familial hypercholesterolemia? It's an inherited condition. People with FH are born with it. In fact, the damage to the arteries starts in utero. They have very high levels of LDL, or bad cholesterol, and they have early cardiac events like this gentleman. Most people, as you'll learn in the next few moments, have a very high risk of having heart disease throughout their lifetime. Men that are untreated have a 50% chance of having a heart attack by age 50. Women untreated have a 30% chance by age 60. Much higher risk of early death. This is a dominant gene. And what are dominant genes? A dominant gene is, if a child has that for familial hypercholesterolemia, you just need one copy of the gene from one parent, and then you've got the disease. Unlike a recessive disease, in which the child has to get a gene from each parent to get the disease. So this is a dominant disease, and you have one gene, you have the disease. So what are some examples of dominant genes? Well, brown eyes. If one parent has blue eyes, they've got 2 blue eye genes. And if a parent has brown eyes, they have at least 1 brown eye gene. They may have 2. And if that child gets that brown eye gene, they're going to have brown eyes. Now, I told you about my wife a minute ago. I married a Norwegian from Minnesota. And when we go to family reunions and we took our daughter every grandmother, aunt would come around, cousins, nieces would come around and look at Emily because Emily had brown eyes and was the first person, like in 6 generations in her family, to have brown eyes. And it was almost like she was a mutation or something. So it's a dominant gene. You have the gene, you have the disease. So what happens when you have the disease? This is age along here, age 3, age 12, age 60. And here's the cholesterol, LDL cholesterol. So our gentleman we just talked about, JB, usually these patients by age 12, before they're teenagers, they have heart disease. And he was a homozygous, so he had a gene from each parent that caused it. But the majority of patients that have it are heterozygous, which means they just have one gene from one parent, but you still have the disease. Now, this is a normal. This is without FH. Most people, they won't manifest heart disease until they're in their 50s. That's when you have a heart attack or you need a stent or something like that. But the FH patients with just one gene, they're on this track where it shows up in the 30s. You can deflect that by treating them with a little bit of statin early on. Having them change their lifestyle doesn't really help much, so that they should do it. But it's usually medications. Treating them early on can delay, but not prevent completely the risk of heart attack. Other risk factors are important. You need to control things like smoking, hypertension, diabetes, obviously. But that gene is so dominant, they need aggressive care. Now, what causes this? It's basically 3 genes that have been shown to cause it. There's a couple of thousand mutations so far that have been shown. The most common one is the LDL. So that's the bad cholesterol. And the LDL particle cannot match up with the receptor in the liver. So the LDL cholesterol cannot be metabolized. And I tell patients this is like your garbage can that you put your garbage in. The garbage can lid is stuck shut and you can't put the garbage in it, so you can't throw out the garbage. The second most common is the apolipoprotein B, or called ApoB. That's part of the of every LDL molecule has one ApoB receptor site. That also doesn't allow the garbage to fit into the garbage can. And then the third most common is the PCSK9 gene. It's a protein that actually holds the LDL particle and the receptor together. So as they go into the liver cell, they can, usually the liver cell will then take the LDL out, metabolize it, and sends the receptor back out to get another one. It can't work. The receptor and the LDL fit together like a key in a lock, and they both get destroyed. So I tell patients it's like putting your garbage out on Wednesday and the garbage man comes and takes your garbage, but he also takes your garbage can. And so you have to go back to Walmart or the next favorite store and get a new one. And that receptor can be used a couple hundred times. So it can really help it a lot if you can disassociate those. So those are the 3 big genes that cause it. So it's an autosomal dominant disease. If the father's affected, the mother's unaffected, and the father has an affected gene, and he gives that gene to a child, then that child has the disease. Now, what if we do genetic testing with severely elevated LDL cholesterol, but the genetic testing is negative? And this happens a lot, and it's a big deal because genetic testing is about $2,500. Well, it could be a variant of uncertain significance or undetermined significance, a VUS, meaning that we think it's causing the disease, but we haven't identified all the genes yet. And that's a very common thing to have happen. So it goes into a data bank, and if enough patients show up that have that gene and have high cholesterol, then they eventually say that's probably a gene that causes FH. They can have polygenic hypercholesterolemia, meaning there are many, many different genes you may have that aren't so bad as this one, but they all add up and give you a very high cholesterol. And that can also be due to just a bad lifestyle. You can have certain secondary causes, we'll talk in a moment. Proteinuria, if there's a lot of protein in your urine, or you have cholestasis, meaning that the liver can't mobilize the bile adequately. The classic disease here is primary biliary cirrhosis. to think of that can cause severely high cholesterols like this. And then finally, lifestyle. We can actually overeat our drugs and raise our cholesterol so much. I've had patients with LDLs of 250. They go down to 70 with changing lifestyle. One of them was drinking cream milkshakes because she went with her friend to the cancer clinic where they get their cancer patients to try to gain weight, and she needed to gain some weight. And she started, they have cream milkshakes at the MD Anderson Cancer Center. And she thought, well, I'll try to gain some weight. So she was eating 3 cream milkshakes a day. Now, how early does atherosclerosis show up in FH in the heterozygous? I mean, you just have one gene, not like our earlier patient that had disease. But when doing carotid intermedial thickness ultrasounds, which is the thickness of one of the linings of your arteries to your head, from about age 7.5 years, there starts to be a difference in the carotid intermedial thickness in siblings that have FH compared to their sibling that does not have FH. So we start to see changes very, very early, even in this when you have only one gene from one parent. So what we try to do is have criteria. We have different criteria to diagnose FH. This is a confusing slide, and it's meant to be confusing, I think. There are 3 basic criteria: the Dutch criteria, which is from the Netherlands, the Simon Broom criteria, which is from the UK, and the US MedPed, which is medical early diagnosis prevents early death, from Utah. And they're all different. And anytime we have different criteria for diagnosing a disease, it gets very confusing, I think, to clinicians, and we tend not to use one, although the one we use the most is the Dutch criteria. But to put it simply, 1 in about 250 people in the United States have heterozygous FH. So there's 1 that has it. If you took people off the street and did genetic testing on every one of them, which isn't worth it, because 1 out of 250 is really not worth it to go out and find it. So if you do genetic testing on everybody that comes along, 1 out of 250, you have to test 250 people to find 1. The ACC-AHA guidelines warn us that if a patient has an LDL over 190, we should start to be very suspicious of them having familial hypercholesterolemia. But what if we genetically tested every patient that walked in the door with an LDL over 190? There you'd have to test about 58 patients to find 1. So that's less than 2%. That's really not worth it either. So I don't know if any of you have any patients in your practice that have FH. But if you look at patients that have an acute coronary syndrome, heart attack, unstable angina, need a stent for unstable reasons, and they're under age 65 or under, and they have an LDL at least 160, what are the chances of that person having FH? 11, 1 in 11. So you need to find 11 patients like that. And I've got hundreds of patients like this in my practice. This is where we find our patients. They come from the CCU. They come from the emergency room. They come in with chest pain at a young age, and they have high cholesterol. And these are the ones that we really need to find and start a program. So if you have a hospital you work at, talk to the guys in the ER of sending them to you. If you work in the CCU, talk to them about standardly having them sent to you to be looked for this disease. So less than 65, 65 or less, LDL 160 or greater, doesn't matter if they're on a statin or not. The prevalence is about 9%. If you do Dutch lipid criteria for this, you miss almost half the patients. So there's, the Dutch lipid criteria, which is the best we have, really isn't that good in identifying these patients. You have to have a very high clinical suspicion, and genetic testing should be performed. And one other reason to do genetic testing is that if you find a person that has a gene, then that's the proband, that's the initial person, then you can start to look in family members, brothers, sisters, parents, aunts, uncles, cousins, and you'll usually find about 6 more patients in the family that have it. So 90% of patients that have this in the United States don't know they have it. The CDC came out about 3 or 4 years ago and said there are 3 diseases we need to find early in life and treat early in life because they're going to cause disease. One is the breast cancer gene. One is the colon cancer gene with Lynch's syndrome, with the polyps, and the third is cholesterol. And if the C stands for cancer, like breast cancer or colon cancer, we have telethons. We have people on TV getting colonoscopies. We have mammograms, people lining up for mammograms. If C stands for cholesterol, patients say, that's a myth. I've read about that on the internet. Cholesterol doesn't really hurt me. I'm not going to do anything about that. We have a database we're looking at of 74,000 patients with FH, and only 500 are on these new drugs. The majority of the reasons is because the patient doesn't want it. When you see a patient with very high cholesterol, always think of other causes though. The two big ones are the liver disease with the high alkaline phosphatase, primary biliary cirrhosis, or nephrotic syndrome, which is the protein in the urine I talked about. Others can cause it, but these are the two you do not want to miss. Now, the other thing is physical exam. I encourage you to, when you see patients like this, think of the physical exam. Tendons can be affected. These are the Achilles tendons. You start to see thickening in cholesterol deposits. Xanthomas can be present, like a lump in the Achilles tendon, or an Achilles diameter greater than 11 millimeters by feel, or 9 millimeters by x-ray, if you want to do just an x-ray. They have xanthelasmas, these white plaques under the eyes. They can be in the hand tendons. And some people just have what's called eruptive xanthomas, these little, almost like little pimples, can be on their arms, their torso. This is on the buttocks. So look for these and ask patients if they've ever had them, because they go away quickly when patients go on a statin. So is the physical exam useful? You know, people don't think physical exam is very useful anymore. But in this case, it's very useful. Because if you can find any of these things, the eruptive xanthoma, the tendons, the xanthelasma, the thick Achilles, then you can find the patients that are more at risk for early heart attack. And you get much greater reimbursement, much higher chance of getting reimbursed for their expensive drugs. So think of the xanthelasmas, think of the corneal arcus, which is a cholesterol deposit. You can see how there's white line here. It's usually in the bottom half. This patient has it both the top and the bottom, but it's a cholesterol deposit and the thickening, and that all leads to early atherosclerosis. Now, this is the Dutch criteria, and it has a family history component to the Dutch criteria. If they have premature coronary disease or peripheral arterial disease or high LDLs, you get a point. If they have xanthomas and arcus cornealis in family history, that's that white ring in the eye, that's 2 points. If the patient you're seeing actually has premature coronary disease, that's a couple of points. If they have premature cerebrovascular or peripheral arterial disease, you get a point. But look at the tendon xanthomas. You get 6 points for that. So these physical exam findings are very important. And then LDLs over 330, you get 8 points. And this is millimoles here if you're from Canada or used to millimoles. So, and then the genetic testing is 8 points. So these are all added up. If you have at least 8 points, that's a definite FH, and the reimbursement's much better. And those are the patients that need to be treated aggressively, and their family members look for other elevated cholesterol. Now, do these clinical signs and genetic testing combined, do they indicate a higher risk in patients with LDL over 190? So what if you find a patient with high LDL and you do these physical exam findings and you do genetic testing? And here are the exam findings we've talked about. And here are the genetic, genetic abnormalities, at least in this study, was 79% of the patients. And about 76% of the patients in this study had physical exam findings. And you can see that if you have neither clinical exam findings or mutation genetic, that's a reference of 1. But if you had clinical signs, their risk for coronary disease went up to about 4.6 times higher. If they just had a gene that was abnormal, their risk was only 3.4 times higher. So it's actually even a better risk stratifier to find these physical exam findings. And if you get both of them together, it's almost 12 times higher. So it's an additive effect of both the physical exam findings and the genetic findings. So that's very important to do. So when do you think of familial hypercholesterolemia? When you see this high LDL cholesterol and you start to have a family history of early coronary disease, or if the patient that's in front of you has an early history of coronary disease, think of it and start to do the physical exam. Start to talk to them about their family members, not just first degree, but second degree, third degree. And as this shows, the cumulative risk of coronary disease goes out not just first degree, not just second degree, but all the way to third degree family members. So this is third degree. The risk is much higher out to third degree. So remember, that's like great grandparents, that's like great aunts, uncles, second cousins, things like that. So if you go to family reunions, ask around. Say, did anybody in our family have any early heart attacks? Now, as I said earlier, less than 10% of the U.S. population with FH is diagnosed. In some countries like Netherlands, it's about 90% of the patients that have it. It's known. This is a map of the world, and what do you think these blue things are? Like some of these countries or some of the states. Florida is a blue state. And this is not a political observation. But blue is where it's legal to marry your first cousin. And the majority of the world is that way, actually. All of South America, China, or Russia, lots of the Middle East and Northern Africa, some of the states here. So if you have two first cousins that marry, in fact, in the Netherlands, they have a registry they go to and say, you know, if you want to marry your first cousin, look up the registry first and see what the gene pool is, because you don't want to have a chance of having two genes get together. The other thing is, if you find patients that have FH or early coronary disease, oftentimes we will check a lipoprotein A level. In the general population, lipoprotein A, which is one of the, it's a protein, a cholesterol protein that's similar to LDL. It couples with LDL and they're more damaging to the arteries, and you have a higher incidence of heart disease. You can see if patients don't have heart disease, then they usually have a lower Lp(a) than if they do have heart disease. But in the general population, lipoprotein A elevation is about 14% of patients. In patients with heterozygous FH, it's high in 55%. So it's probably a gene association, but always look for that, because if they have a high lipoprotein A, their risk is even higher to have future events. Now, when we do genetic testing, there's a lot of issues that come up. Families have a lot of questions. You know, you have to talk to them. What are the implications of the genetics? Can they hold it against me? They can't hold it against you for insurance purposes. Is there, you know, there's a fear factor. People, if I have this gene, am I going to drop over dead? They want to know, does it predict side effects? It does seem to predict medication adherence. If patients have a gene, they're more likely to actually take their medications to lower their cholesterol. They have questions about insurance. They have questions about pregnancy. We tell everyone that's thinking of getting pregnant, stop all statins. The second you think of getting pregnant, don't restart them until you stop breastfeeding for women. And then what about lifestyle behaviors? Does it matter? Yes, it matters a lot. It's very important. Even if you have the gene, the lifestyle is extremely important. So how do you treat FH? The lifestyle, get rid of trans fats. Fortunately, that's been outlawed in this country. A low saturated animal fat diet with lots of plants. There's about 350,000 edible plants on this planet. That's what we've been eating for thousands of years, and we should continue to eat more of them, especially if you have FH. Lots of physical activity. The statins, ezetimibe or Zetia. We add other drugs, or even apheresis, which is like a dialysis for cholesterol. But now with the PCSK9 inhibitors, I know Mafus is going to talk about that. That's very important and very helpful. So know these signs, know the very high LDL cholesterol level when you see it at a young age. Especially think of testing or looking at the family further. The guidelines say that patients that you suspect it in should be tested probably at age 2 years and again at age 12 years. 190 is the number we think of, but even 160 LDL in kids is quite high, and that can be an indicator of FH. Look for nodules on their skin, on their tendons, on their eyelids. Start to think of initial treatments, even small doses. The youngest child I've treated was brought to me by his mother and his uncle, his father's brother, because his father had just died at age 28 of an MI. And the child was 2.5. And I called one of our pediatric endocrinologists because I don't feel comfortable treating those young children. And we started him on a statin, 10 milligrams of atorvastatin, didn't do it. Went up to, that's about the maximum they allow at that age. We added ezetimibe, and we've gotten his LDL down from about 350 down to about 140, which is a pretty good reduction. But it's still not perfect. But he'll have a lifetime of this, hopefully a long lifetime, to deal with it. How to treat it, the combination therapy, meds, PCSK9 inhibitors. If a parent has FH, there's a 50% chance that a child will have it. So consider screening everybody in the family. Once you find that gene in one person, you just test for that gene in the rest of the family. So I said earlier that gene testing is over a couple $1,000. But if it's one gene you look for, all it costs is about $100. So everybody in the family, once you find the gene, can be tested quite inexpensively. So 3 quick questions. Familial hypercholesterolemia, what's the incidence of FH in the general population? As I said, it's about 1 in 250. What's the incidence of a positive genetic test for FH in acute coronary syndromes patients that are 65 or younger with an LDL of 160 or over? That's about 1 in 10. So that's a very rich population to test. And then finally, in patients with FH, which relatives are at increased risk for early CAD? Is there no increased risk, only the patient? Or is it 1st degree, 2nd degree, 3rd degree relatives, 4th degree? As I said, it's up to 3rd degree relatives. So you need to take a more extended history, not just the 1st degree of family history. Go out to 3rd degree. So thank you for your attention, and it's great to be in Sarasota.